All right, so you've been suffering with some back pain, but the pain down your leg or the pain down your arm, it's been excruciating. You go see your doctor, you get an MRI. The MRI has all these terms and you're trying to make heads or tails of it, and it starts talking to you about a disc injury or a disc bulge, a disc protrusion, a disc extrusion, or something called a sequestration. What do all those things mean? What does the research say is a better way of treatment? What are the risks? What are the benefits? When should you take some of these findings with a grain of salt? And when should you go straight to the emergency room? My name is Dr. Paul Groulx, chiropractor in Ottawa, Merivale Road. If this video was helpful, like the video, subscribe. I like to make content like this to help you get more informed, take control over your health so you can live a pain-free life. So first of all, what is a disc? Boom, here is my friendly spine. You've got spinal bones, we call them vertebrae. And in between these bones, you can see these sort of cream-colored spacers. Those are the discs. And a lot of times, it's sort of a common thing to say is that the discs are a bit of the shock absorber of the spine. It's sort of true. Its primary role, though, is to give your spine its ability to move and bend and twist. The discs, when they're healthy, act as a bit of a pivot point that allows the spine to move. Because if you didn't have these discs, you just have all these bones, and you would look like the Tin Man on The Wizard of Oz. And then you see on this model, you see this yellow material, and they're sticking out on both sides, and then inside this, you have more of the yellow down the inside of the spine. So the ones that stick out on the edges, those are the nerves, and in the low back, they create something called the sciatic nerve that goes down into your buttock and down to your leg, right down to your foot. And the nerves in your neck, they do something similar. They go down into your arms and in your fingers. So there's the basic anatomy. So now what we're going to do is we're going to look down the spine from the top to the bottom. All right, so step one is, let's look and see what the disc actually looks like. If you look at a disc, you'll notice so this is your nose, this is your forehead, you're looking this way. And this is your buttocks back here. Anyway, I don't know why I drew the buttocks. So the disc is made of these rings, these outer rings, kind of like the rings of a tree. When you look at a tree stump, you can see the rings of the tree, and you can count the rings and how old is the tree. It looks similar. A disc looks surprisingly similar. Yet they have these outer rings, and they're very tough, and they're fibrous. In fact, they're called the Annulus fibrosus. That's a term that you can see in your MRI or CT report, or sometimes they'll just say the annular fibers, or just the annulus. It's all the same thing. So these are the outer rings, and on the inside, you have something called the nucleus. Think back to grade 12 biology, the nucleus of the center, the epicenter of a cell. The nucleus, the disc has an epicenter as well, and it's also called a nucleus, but it's called a nucleus pulposus. So you see that on your CT or MRI, that's what it's referring to, the epicenter of the cell. And it's not as tough and fibrous as the outer parts. It's a little bit more jelly-like. So my best example, comparison, is think of a jelly donut. Your disc is like a jelly donut. The outer part of the jelly donut, the pastry part, that's the annulus, and the jelly filling, that's the nucleus pulposus. So to understand what a disc bulge is, or disc protrusion, for the sake of this video, we're going to say that those two things are essentially the same. There are some minor differences, but let's keep it simple. A protrusion and a bulge, we're going to consider them to be the same thing. By the way, people talk about a slipped disc, and when they get sciatica, your disc does not slip. It's impossible. The disc does not slip, but it does bulge. It does protrude. So anytime you hear of somebody having a slipped disc, it's a protrusion or a bulge. So in a disc bulge, let's go back to the jelly donut. My hands are the spinal bones, okay? And in the middle, you've got a jelly donut. And a disc bulge, just imagine what would happen to the overall shape of the jelly donut, the pastry part, if you were to squeeze it just enough that you see the overall shape of the donut deform. It's kind of the same thing with a disc. If you have a disc bulge, what starts to happen is that these rings, the annulus, start to become a little bit deformed, and you can see a bulge or a protrusion in the disc, in the outer edges of the disc. The problem with that is that nearby you can have a nerve. So let's say that's the nerve right through here. You can have a nerve that's nearby, and this disc starts to bulge, and it puts pressure on that nerve. And when that nerve gets irritated, it creates sciatica. So when that nerve gets irritated, it creates that sciatic pain that you feel in your buttock or in your leg, or if in the case of your neck, the pain down your arm. On your MRI or CT report, they may use a word radiculitis or radiculopathy. Those are just fancy words for nerve pain or nerve irritation. So nerve irritation, radiculitis. So radiculitis is ridiculous pain. That's how you can remember that. That's what that means. So that's a disc bulge or a disc protrusion. A disc herniation is a little bit different, and it starts to get potentially a little bit more serious. That's when the nucleus starts to become more involved, and the nucleus starts to break through. So it's no longer contained at the epicenter of the disc, but it starts to migrate towards the outer ring. And it's breaking through some of these rings, but it hasn't broken through the outermost ring. That's a herniation, and what that does is that will exaggerate or worsen the bulging, because now the nucleus is pushing through, is part of the deal. The nucleus is part of this migration and bulging of the disc. That's a herniation, and usually that can create more pain, more pressure on the disc. By the way, you can have no herniation and very little bulging and still have radiculitis, this ridiculous pain down into your buttocks and into your leg, the sciatica. And then on MRI, it shows no contact between the disc and the nerve. So how does that happen? Very simply, have you ever bumped your head and you get a goose egg? Well, that goose egg, that lump, that inflammatory process on your forehead when you have a goose egg, that takes up space. It bulges. And that's just an inflammatory process. Well, the disc can be injured, and the surrounding tissues can be injured. And there's very little bulge, but there is significant swelling. There's a significant inflammatory process that occupies enough space that it impinges on the nerves and causes radiculitis or nerve pain. So we've got disc protrusion, we've got a disc bulge. We're not slipping discs anymore. We're never going to use that terminology again. We're understanding herniation, right? The nucleus is now involved. It is pushing through the rings, exaggerating this bulge, putting pressure on nerve. But it hasn't broken through the outer ring. That's a herniation. So this is when, okay, let's go back to the jelly donut. You squeezing and squeezing and squeezing, and there's more and more deformity of that donut, that outer pastry. The jelly filling is starting to move to that outer edge of the donut, but it hasn't come out and spilled out of the donut yet. That is a disc herniation. Now, an extrusion. So an extrusion basically means the herniation or the nucleus is now breaking through that outer ring. It is now breaking through that outer ring. It's escaping. The jelly donut, you can now squeeze it enough that the jelly filling is starting to come out of the pastry, and it's visible. It's spilling out. That is an extrusion. And oftentimes that's associated with more pain, more neurological symptoms, some weakness, some numbness, some tingling. Things are getting a little bit more inconvenient. So the last thing you might see is something called as a sequestration. So it comes from the word to sequester. So what does sequester mean? Well, think of like a courtroom. They sequester the jury. They separate the jury and they isolate the jury from the rest of society to protect the legal proceeding. But a sequestered jury is a jury that's been pulled apart from everything else. A sequestered disc is when this herniation, this disc material, so the part of the nucleus and the disc material breaks off. It becomes sequestered or pulled apart from the main structure. And when it pulls apart and it becomes sequestered, it can migrate, become free-floating, and occupy space that is normally reserved for the spinal cord. And that's a big deal. In my years of experience, the time that I record this video, I've been a chiropractor for 22 years, and cases that have not worked out in the office and have ended up being a surgical case, in more cases than not, they are sequestered discs. They're a little bit more complicated. Many times the surgeon has to go in, find it, and remove that sequestered bit. Now, does it mean absolutely if you have a sequestered disc that you're going to need surgery? No. It's amazing. Your body has an amazing capacity for healing, and sometimes those sequestered parts of the disc can heal and become reabsorbed into the body, And for reasons that we can't fully explain, the patient heals, which is fantastic. Because if you can avoid surgery, if I can avoid surgery, I don't know about you, I am a chiropractor, but I'm not your chiropractor, so don't take this as advice. I would not sign up for surgery unless I had tried and exhausted every other method. Because even minimally invasive surgery, it's not minimal. They're still cutting through many layers of the spine and many layers of the muscles and through tendons and ligaments that don't heal very well and will never be like it was before. And then they take away, in many cases, they shave parts of the bone or even remove parts of the bone. That's just not something I'm going to sign up for unless I had tried everything else, given it a real solid try, and nothing has helped. And I've exhausted all possibilities, and I was still being impaired by terrible pain, then I would consider surgery. Got to give surgery credit. In the short term, if someone has, here's what the research says. In the short term, if someone has leg pain, if you compare conservative care, so things like chiropractic, acupuncture, physiotherapy, those are the main ones, exercise programs, physical rehabilitation. Those are all conservative care. If you compare conservative care to surgical care, from the beginning of the symptoms to 3 months out, surgery is superior in terms of resolving pain. No question. And I give full props and credit to surgical. I mean, it's an amazing skill. 3 months out, surgery wins almost every time. However, when you compare the same types of people 3 months out and 12 months out, and you compare the surgical group to the conservative care group, the results are essentially the same. So even if surgery is going to help you in the first 3 months to resolve your pain, 12 months later you'd be in the same boat as if you've never had surgery and all you did was conservative care. Now here's where I would absolutely rush to the operating table and rush to the emergency room if it was me and I was managing or dealing with a disc herniation, more than likely an extrusion or a sequestration, is if I had symptoms or that I was developing something called Cauda equina syndrome. Let's go back to this diagram. This is your back, this is your front. You'll notice that I drew this diagram where a herniation goes backwards and to the side. Something called, you'll see this in a CT or MRI report, posterolateral. It's a posterolateral disc bulge, extrusion, sequestration, disc herniation, posterolateral. It's towards the back and on an angle is the most common direction of a herniation, bulges, extrusion, sequestration. In some cases, the disc herniation doesn't go out on an angle like this, where it irritates the individual nerve that goes down one leg. Sometimes it goes straight back, or you'll see on the MRI or CT report called a central disc herniation. And that's where all the disc material in the nucleus goes straight back. What do we find in this space, straight back? We find the spinal cord. We're no longer dealing with individual little nerves, which can be super painful. We're now putting pressure on a spinal cord, and that's a much bigger deal, creates more serious problems. In Cauda equina syndrome, there's enough rearward or posterior migration of the disc material that it starts to put pressure on the Cauda equina, or the nerve fibers at the bottom of your spinal cord that goes to your bladder, part of your bowels, your pelvic floor, your legs, all the way down to your toes. And when that happens, you get something called saddle paresthesia. So saddle paresthesia, imagine you were sitting on a horse in a saddle. So which part of your body is coming into contact with the saddle? It's your inner thighs, your groin, your buttocks. And if you start to get cold sensations or numbness or tingling in that saddle region, that's something called saddle paresthesia. It's a major symptom of this Cauda equina syndrome, with this pressure directly of the disc herniation, the disc material, right onto the spinal cord. Not good, and you're one step closer to having emergency surgery. One of the complications of Cauda equina syndrome is losing control of your bowel or your bladder. So just an unusual inability to control your bowel or your bladder. If that happened to me, I had saddle paresthesia, I've been dealing with a disc herniation, I'm going straight to emerge. I'm demanding a CT scan, an MRI, and it's very likely that it's an emergency surgical procedure to save control of your bowel or bladder. You can lose control of your bowel and bladder, permanently becoming continent. If you're having those symptoms, you need closer attention, for sure. Lastly, how common are disc herniations, and what is the likelihood that they can heal on their own? Glad you asked. There was a study in 2015 that looked at how frequent, the prevalence of disc herniations and disc bulges in the community at large. It estimated that up to 20% of people who are walking around in public with no symptoms, no radicular pain, no sciatic pain, no pain down the arm, asymptomatic, up to 20% of these people have disc bulges. And all it takes is a bulge. It's on the other sheet. All it takes is a bulge to create nerve pain, to create sciatica. And up to 20% of people have bulges and have no symptoms whatsoever. Ironically, it's the people with the most acute disc herniations that tend to have the better and more complete recoveries. Your body has an amazing capacity to heal. And one of the theories is that in the really acute disc herniations with all the inflammation, the terrible pain down the leg, your immune system is recruited to this chaotic storm that's happening in your body, and it deepens the healing, making it more complete and a better overall outcome. The herniations that I see in the office that are more low-grade, chronic, slightly bulging, low-grade inflammation, manageable but distracting, those are the ones that are actually that take longer to heal and are more difficult to see restored. So if you are in agonizing pain, you have terrible leg pain or arm pain, you may be in a circumstance where you have a better outcome than someone who has a disc herniation but is more low-grade, chronic, and just achy all the time. I know it's counterintuitive, but that's how it is. All right, I think I covered everything. My name is Dr. Paul Groulx, chiropractor in Ottawa, Merivale Road. If this video was helpful, like the video, subscribe. I like to make content like this to help you get more informed, take control over your health so you can live a pain-free life. See you later.